But
This is my non-medical section.
I love that. I love reading. I kind of just wanna I would talk to you about this more, but I think we're like on time for the session to begin right now.
Yeah.
Oh, I think you're supposed to put it horizontally, is what I'm assuming. I'm sorry.
Is that okay?
Oh, okay. Okay. So are we settled, doctor? Are we good? I think we've gone live now.
Okay.
Okay, so good morning. How are you doing?
Very good. Glad to be here.
Thank you for taking the time to be with us. We appreciate it so much. We understand how busy you are. Before we get into the questions, could you tell us a little something about yourself, please?
Um, sure. My name is Asad Raffiq. I'm a GI doctor practicing in Chicago, Illinois.
Mhm.
I'm a graduate of Deccan Medical School in Hyderabad. I finished my med school there and I decided to move over and I did my internal medicine and GI all from John H. Stroger Hospital in Cook County, which is one of the premier hospitals here in Chicago. Um, been practicing GI for the last 15 years. And right now I'm involved with a private practice in the suburbs of Chicago.
So you're from Hyderabad. Do you miss Hyderabad? Have you visited recently? Because I'm from Hyderabad. I love this city.
Yeah, nothing like it. I make it a point to go back at least once or twice a year.
Mm-hmm.
Um, I still have some roots in Hyderabad. Take my mom with me, and I go there once a year at least.
Mm-hmm. Thank you. So I think we're going to take audience questions in a bit, but before we get into that, I'd just like to ask you a few questions in general, if that's okay. So I
Sure.
think I want to start off with like asking you, what do you think is like the ultimate tip for like liver or just like GIT health in general?
Um, GI is basically a very complex organ system. It has multiple uh, organs, and a lot has to do with what you are doing with your food. Um, there's a section of GI problems that are directly related to food in terms of how much you eat, what you eat, and how you spend that energy. Anything excessive or anything that is inflammatory will lead to problems. So it has to be a nice balance wherein you will basically try to spend what you're getting in.
Mhm. And how would you say stress usually affects our like gut health?
See, there's multiple conditions in which stress has a direct role to play. Sometimes the stress will make you feel the problem more than what it is. There is definitely a component in the functional bowel disorders in which stress is going to make you feel the condition, the symptoms more than what they usually are. It's a big complex system. There is a system in the body wherein your gut is always interacting with your brain. It's called the brain-gut axis. If that happens, if that is altered, actually, you end up having a lot of symptoms like bloating and uh, other symptoms like nausea, stuff like that, functional diseases. They'll make you feel a whole lot more severe as they move on, progress.
Thank you. So I think we're just going to jump right into the audience questions now. So we have our first question here. I'm going to read it out for you. The question goes, my dad keeps complaining about a burning sensation in his chest after meals and sometimes wakes up coughing at night. Could this be acid reflux or should we be more concerned?
The way the symptoms are presenting itself, seemingly it's a middle-aged person with heartburn. That's how we classify the symptom as. It's mainly burning sensation in the chest. Um, yes, definitely it could be acid reflux disease, which is basically a sensation of burning associated with the reflux of acid coming into your food pipe and irritating it. Sometimes it does not even have to irritate it, it just stimulates the nerves. And that's what you end up feeling like the sensation of heartburn. So, yes, it could be good. In addition, we can also think of other conditions. Things like coronary artery disease with atypical symptoms can also present like this. Asthma can present like this. Sometimes food allergies, eosinophilic esophagitis. There's multiple conditions that can end up causing these kind of symptoms. But the way things are presenting itself, as you have stated, this gentleman should be ruled out for good. Yes.
Um, and how would you say that you would know that the symptoms are severe enough to go see a gastroenterologist? Like, how, at what time would you say the patient should come and see their doctor? What symptoms would that point out to?
It's a good question. We are looking for things like what we call as alarm symptoms as such, wherein we see that the onset of symptoms is relatively late in life. It's associated with other problems like difficulty swallowing, weight loss. If somebody has been a smoker for a long period of time, and they also have family history of cancer, stuff like that, those should prompt a more thorough investigation, a more thorough evaluation. It's, I think, at that point. And also, many a times, what happens is people are self medicating themselves. Right now, acid reflux medications like antacids and PPI therapies, they're all available over the counter. So people end up using them. And once the patient has been using these kind of agents for some period of time and they're not feeling the benefit from it, that should prompt you um, to get an evaluation by a GI physician, because it could be something else or it could be just more advanced disease than what it is seemingly there.
Mhm. Doctor, can you break down GERD for us? Like, can you explain to us what it is and what the prognosis looks like and what we usually see and how we can rule out somebody with GERD?
It's a very very common problem with massive medical costs, and it's present in all patient populations, even from childhood all the way to old people. You know, it's basically defined as the abnormal presence of acid, excessive presence of acid coming from your stomach going into your food pipe, causing symptoms of heartburn and burning, etc. That's what the GERD is defined as, and it can lead to a lot of problems. It's not just the presence of acid, but it is the damage that is caused by the acid is causing the symptoms too. Here in the Western Hemisphere, GERD is a big problem, and it's been shown that it can proceed and progress towards permanent damage to the lower part of your food pipe. It's a condition called Barrett's esophagus. It's a complication of GERD. Like that, other complications can also happen by this acid-induced damage in your food pipe that can cause things like reflux esophagitis, strictures. And when you have Barrett's esophagus, you are at a higher risk of developing esophageal cancer too. So it's been shown that amongst all the other cancers, the fastest growing cancer in the Western Hemisphere, specifically US, is actually the GERD-induced Barrett's esophagus-related adenocarcinoma. So it's a serious condition if ignored. So if we identify the problem, the best thing would be to intervene early, treat the condition, so that we can prevent these complications.
Mhm. And what does the treatment for GERD look like, doctor?
Right now, right off the bat, it's a sequence of treatment map that we see. Uh, let's say any regular person like you and me, we develop heartburn. What we try to do is we try to modify our diet. We try to eat less of spicy foods that can make your symptoms worse. We then start using over-the-counter medications like antacids. We start using medications like Pepsid, or we start using medications like omeprazole, pantoprazole, things like that. And once we start using them, we see some benefit. Majority of the patients are relegated to medical management, which means that we are treating them with medicines. The usually common class of medications is the one I just mentioned to you. We treat those. There are a couple of new developments. So there's a new class of medication that have come out. They also are basically the potassium channel blockers that help in reducing the acid content of your stomach. They reduce the acid production, which is a response to your meals and even the basic There's a level of acid production going on as a basal rate. That also seemingly is reduced by these medications. So first of all, we try diet, then we go on to these medications and we sequentially build up on these medications. If one class of medication is not working, and then slowly we build up and we proceed towards full dose, things like that. Now, in a select subset of patients wherein we are seeing that these medications are not actually fully effective, then we proceed towards non-medical treatments. There are a couple of endoscopic therapies now that are being tried here in the US. One is the magnetic device, wherein we put a ring of magnets around the food pipe, which actually augments the sphincter that controls the 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 entry of acid into the food pipe. So that has become loose. We try to alter that by doing a magnetic augmentation, which is like a ring that helps in the closure of the sphincter. The other modality is called a TIF procedure, which is an endoscopic procedure. We go in and we do a fundoplication all with endoscopy. And beyond this, the other option left on the table would be the surgeries. In the surgical strata, we think of doing like a toupee procedure, a fundoplication, all of which is basically aiming towards reduction of the acid coming into your food pipe by strengthening your ring muscle, which is your sphincter, right at the end of your food pipe, just above the stomach.
Mhm. And doctor, do you find that like stress or anxiety usually triggers GERD?
Yes, there's lots of condition that actually affect your symptoms of heartburn and GERD. There's a long list actually. Things like lack of sleep, different dietary habits, horizontal positioning right after meals, all these conditions, other medications, your gastric emptying times, your your salivary secretions, all of these can affect ultimately how and what happens in your food pipe and your gastric situation. Stress is one of them. If stress causes anxiety, lack of sleep, it again leads to increased sensation, increased perception of the underlying damage and the inflammation.
Mhm. And doctor, for people suffering with acid reflux at night, would you say that there's a particular position that you'd recommend for them to sleep in?
Well, it's been shown that the left lateral decubitus position, which is sleeping on your left side, it leads to a little less exposure of acid coming into your food pipe, because what happens during nighttime is usually your stomach's full. The habits of people mostly are towards the end of the day they have a dinner, which actually most of the times is the heaviest meal of the day, which is not the best thing, right? So when the stomach is full, when you lie down, the angulation of the food pipe in the stomach, in the left side, it actually decreases the reflux actually, because the left side of your body, your stomach's more prone towards the left side. The fundus of the stomach, which is the biggest part of the stomach, is more towards the left side of the body. So when you lie down on your left side, the food tends to get uh, accommodated over there and comes back up less. Whereas compared to the right side, there has been studies which have proven that the amount of reflux coming into your food pipe is relatively much less in the right position as compared to the left.
Mhm. And doctor, do you find that GERD in some cases does cause sore throat or coughing without the heartburn symptoms?
Yes. So these are called the extraesophageal manifestations, other than your regular typical symptoms of heartburn and cough. Sorry, heartburn and regurgitation. Other symptoms that can affect your upper part of the pharynx and your common tract between the breathing tract, that can cause irritation all the way up to the larynx as well. Something that is very common and it's underappreciated. It's called laryngopharyngeal reflux, right? So
Mhm.
what we are telling is that the acid is coming all the way up and is going into your larynx area and irritating it. So that can cause symptoms like throat clearing, wheezing, sore throat, cough. All these can be part of the GERD complex. And these are known as the extraesophageal manifestations.
Mhm. Mhm. Thank you so much for breaking that down for us, Doctor. And to everyone watching, if you have any more questions that you would like for Dr. Asad to address, please put them down in the comment box and we'll get to them as soon as we can. Thank you so much, Doctor. So,
My pleasure.
moving on to the next question. Um, the question goes as so, my sister has been having frequent stomach cramps along with unpredictable bowel habits, sometimes constipation, sometimes diarrhea. Could this be IBS or do we need to rule out something more serious?
Depends on the multiple factors. We actually don't just directly jump to IBS. Yes, there is a possibility that this is IBS. But usually, when a clinician approaches these kind of symptoms, we have to look for other features that are worrisome as well. We go through a sequence of evaluations wherein we try to see if this is something more dangerous or more sinister. Because IBS is a condition which is a complex of symptoms in which you have abdominal pain, you have altered bowel habits, it could be diarrhea, constipation, or alternating diarrhea and constipation. If somebody young is coming to us with these kind of symptoms, there are multiple other things that we need to think of. First of all, just like in GERD, we look for other features that can point towards a more serious problem, like inflammatory bowel disease, like other malabsorptive conditions like celiac disease, things like that we have to think of and rule them out first. So if somebody like this presents to me, what we do is we set them up for us a few simple tests, things like inflammatory markers, and we look for other problematic symptoms, things like if this patient has some bleeding in the stool or is losing weight, then it points towards something more inflammatory, more aggressive, more dangerous. So we go through a sequence and we test for those kind of conditions very empirically. And then we come to our conclusion. If those tests are negative, then we say, hey, most likely this is IBS.
Mhm. And what do you think is like the most common cause for IBS? Like, would you point it out to like antibiotic use or any past gut infections?
There's no one cause as such for IBS. It's a very long list of possible derangements in your intestines. Your intestines are a very complex organ. There's always an interaction going on between the bacterial content of your gut, of your intestines, with the intestines and the motility patterns that you see with this alteration. So it's an interaction going on amongst all these things. And lastly, what happens is your gut is always talking to your brain, right? So the nerve activity that is sending impulses from your intestines all the way to the brain is what you perceive the intestinal sensations as, right? So those all three things can be altered in IBS. So there's not one cause, but it's a complex interaction between all these 3 to 4 things that can lead to your symptoms in IBS.
Hmm. And doctor, do you find that patients often complain to you that their IBS symptoms get worse before their periods?
Yes, because physiologic changes happen in a female when they're approaching their menses. Uh, things like pelvic congestion happens. Things like uh, alteration in the motility patterns happen when you're approaching your periods, and that can cause increased sensation. That is also compounded with anxiety, with other you know psychosomatic situation where it can be perceived as worsening IBS.
Mhm. And doctor, is IBS a lifelong condition or can it be reversed? What does the treatment look like?
It's a multi-pronged treatment. It can be reversed. It's basically a symptom complex, right? It's a bunch of symptoms that are put together and we have given it a diagnosis. So if we treat the patient and we try to get to the root cause, sometimes simple things like some medications can cause or worsen the symptoms of IBS. And if we get rid of those medications, that's one thing we can do. We can try eliminating some foods from your diet, and things like many of people who think that they have IBS can have lactose intolerance, for instance, right? So if we get rid of lactose from the diet, that can help. There's lots of other subsets of patients that have isolated food allergies, very common peanut allergies, nut allergies, sesame oil, sesame seeds, other nuts can also be a very common cause. A lot of these things, milk protein allergy, wheat allergies, all of these food allergies can also cause the common symptoms of bloating, diarrhea, and cramping. So all these things, if we identify these type of intolerances, I think IBS can be treated successfully. Yes.
Mm-hmm. And doctor, why do you find that patients often complain of getting tired or foggy when their IBS flares up?
Um, it's a combination of things. It's if it's related to something like celiac disease or something that itself can cause the fogginess of the brain. Um, as I said, it's all about the sensations. The other thing that is very important is IBS is always associated, or most of the times is associated with anxiety and depression. So it could be that the gut symptoms are worsening your depression itself and can cause changes in your sleep cycle. All of these factors can lead to complaints like brain fogginess, increased tiredness, fatigue, you know. But we have to take that with a pinch of salt. We cannot fully pin this on the IBS because of its association with other psych conditions, other things. We always have to think and make sure that it's not a primary problem, like simple things like, if you have malabsorption, it could be B12 deficiency. And that is something that we have to check specifically and rule it out before we actually say, oh, it's nothing, it's just IBS.
Mm-hmm. And doctor, do you always need to do a colonoscopy to diagnose IBS?
No, it's not a first line suggestion. What we end up doing is we first look for other worrisome symptoms. Things like if somebody is bleeding, somebody is greater than 50 years of age, and he's starting to have symptoms at that age, whereas before he was totally fine. In those kind of people, if somebody is losing weight, if somebody has nocturnal diarrhea, what we say is if somebody has to wake up in the middle of the night and poop, that is definitely uh, a different problem because that's a more severe symptom, right? If it's making you wake up from the sleep and making you go to the washroom and have poop, that's called nocturnal diarrhea, and that's one of the alarm symptoms too. So we're looking for these kind of symptoms before we decide whether to do the colonoscopy or not. In these kind of individuals, if these symptoms arise, then we do the colonoscopy first rather than just uh, diagnosing them with IBS.
Mhm. Thank you, doctor. And doctor, could you tell us a little bit more about IBS-C and IBS-D? What's the difference between them, and can they switch over time?
Yes, IBS-C, IBS-D, what the GI doctors did, they sat together, especially the doctors specializing in the functional bowel disorders. They gave us criteria to diagnose IBS, right? So IBS basically is a condition in which you have abdominal pain, cramping, bloating, and it is associated with alteration bowel habits. Okay, the type of bowels you have could be loose or could be hard, and sometimes what we say is that sometimes the patient goes in with a few days of loose stools that is altered with days of hard stools. And sometimes that can also alternate with normal stools. So IBS-D is IBS-diarrhea. It's this diarrhea subtype of IBS, right? So it's pain, bloating associated with loose stools. And on the flip side, IBS-C is people who have pain, bloating associated with decreased stool frequency, which is constipation. So sometimes these fluctuate in between, and they're called as IBS mixed. So the type of pathophysiology is slightly different. It's a more motility issue. If the motility is slow and then you don't poop enough, it's called IBS-C. Whereas in which you have an alteration of bacteria, motility is fast, you end up having more frequent stools associated with the pain and bloating, it's called IBS-D, you know.
Mhm.
They do fluctuate, and sometimes people end up having what we call as IBS mixed.
Mhm. Thank you so much, Doctor. And I think this is the last question for IBS. Could you just tell us more about how probiotics would relate and or help patients with IBS?
Probiotics are still a work in progress. Um, it's not exactly a 1 + 1 2 kind of a science. We have trillions and trillions of bacteria living in our body. As such, a human being is a walking ecosystem. Um, what we do with probiotics is we try to introduce 10 or 12 different types of spores via a pill or a capsule or a liquid formulation. And then we hope that, those kind of spores will go and germinate and populate your intestines, help. Um, every square centimeter in the body, in the intestines, actually, every square centimeter has a billion bacteria, and it's a billion bacteria, 10,000 different types of it. That's usually how uh, the variety of bacteria is there. It's very, very heterogeneous. So, if we are to kind of think that, hey, we're going to give a few months of probiotics and kind of change the whole system, it's a little futile. But um, in people who have a severe alteration, dysbiosis, like we've known people who have been on antibiotics for months and months for various conditions, or people who are on chemotherapy, or people who are on very selective diet because of intolerances. These are type of people with other systemic conditions. They have a severe, what we call as dysbiosis, meaning an alteration in their gut bacteria. In those subsets, a small subset of people, probiotics seems to be helpful. There are conditions like, C. diff colitis, let's say. It's a specific infection. We treat it with severe antibiotics that leads to a complete wipeout of your gut bacteria. So we kind of have to help them, and those are the type of people who will benefit from a course of probiotics.
Mhm. Thank you so much, Doctor. Thank you so much for helping us understand all of that better. Thank you. And to everybody watching, Dr. Asad is still taking questions. So if you have any more questions, please drop them in the comment box and we'll get to them as soon as we can. Thank you. So Doctor, I think we're gonna move on to the next question. The next question goes, so my recent ultrasound showed a fatty liver, but I don't drink alcohol. Should I be worried, and what does this actually mean?
You know, uh, Previously it used to be called as non-alcoholic fatty liver disease. You know, there's lots of causes of fatty liver to begin with. Okay, two main common causes. One is your alcohol liver disease, and the other one is metabolic associated fatty liver disease, right? Dysmetabolism. So fatty liver is now being recognized more and more because of the changes in our dietary habits, in our lifestyles. Um, the liver is not handling the fat as it's supposed to. And it's a very complex mechanism again. It's the way your genes are interacting with your fat intake, and that determines the uptake of fat in the liver. So if there is abnormal storage of fats in your liver, you end up showing it on imaging like this, and that's a condition known as fatty liver disease, right? There are other conditions that we need to think of if you have fatty liver disease, things like hepatitis C, other inborn metabolic disorders of the liver, all of which can cause fatty liver. But in a common situation like what you're mentioning, most likely this is related to your metabolic alteration.
Mhm. And Doctor, can something like fatty liver disease turn into something really serious, like cirrhosis, perhaps?
It is a rampant problem. It's a serious problem. It is a problem that needs to be addressed sooner than later, um, across the world, actually. And at least a third of the patients with fatty liver disease are at high risk of progression towards complications like cirrhosis and liver cancer. So yes, it's a very huge problem, and it needs to be addressed as soon as it is diagnosed.
Mhm. And what lifestyle changes would you recommend to people to reverse their fatty liver disease?
It depends on their comorbid conditions, meaning that what else do they have? If a person is diabetic, we have to make sure that their diabetes is well controlled. If somebody is obese, we have to target their obesity. Um, if somebody is taking other medications that promote fatty liver disease, like steroids and stuff like that, we have to make sure that we get rid of those or we optimize their use. Um, so we try to find out or identify um, secondary causes first, like what else can be done, and then if nothing is found, it's a straightforward dysmetabolic associated fatty liver disease. We suggest lifestyle measures, which include aerobic graded exercises along with reduction or uh, decreasing their carbohydrate intake along with fat intake as well. So it's all get towards a non-inflammatory kind of a diet, which helps with your liver.
Mhm. Uh, and doctor, how would you recommend that patients monitor their liver once they're diagnosed? Like, how often do you think they should get checked?
You know, uh, different medical fraternities have different approaches to this. If somebody has been diagnosed of fatty liver disease, we try to identify whether this fatty liver disease is leading to inflammation, right? It's two different subsets. Starts off as fatty liver, but then as it progresses, it ends up causing inflammation in the liver. When then we do the blood test, we find out that the liver enzyme level is elevated, right? And if that condition is left untreated, it just progresses. It leads to more permanent damage, which is called fibrosis. And that's a precursor to irreversible condition called cirrhosis. So it depends where you are in the sequence of events, right? If you are already starting to see that your liver enzymes are going up, then I would suggest at least 3 to 6 months follow up with your healthcare professional, having regular blood work done, and these days, when you are being seen in the GI clinic, and at least in my clinic, what I end up doing is I try to identify people who are at high risk of progression to cirrhosis. So in those people, I suggest more intensive evaluation and testing.
Mhm. Thank you so much for your insights, doctor. And if anybody hearing this wants to further consult with Dr. Asad or any of our other doctors, please go on to our My American Doctor website. We provide telecommunication services with American specialists for second opinions, or you can call us on 9914941494. Thank you so much, doctor.
My
Uh, I
pleasure.
think I think we'll be taking the next question now. The question goes, so my cousin tested positive for hepatitis B during a routine checkup. He feels completely fine. Can this still be dangerous?
Hepatitis B always is a chronic infection. Sometimes it can be an acute infection too. If you have chronic hepatitis B, it is a very serious condition. It needs treatment. We determine whether the presence of this virus in your liver is leading to problems. What problems? If it's causing active inflammation, and then you see that the virus is dividing in your body or replicating. These are the type of patients who actually need our help. So we help them by treating them with antiviral medications. And we keep monitoring them. We keep an eye on how the liver looks, because it's not just the inflammation and the cirrhosis development that is at risk, but also hepatitis B itself can cause liver cancer too. So we have to keep evaluating and checking ultrasounds every 6 months or so. That's what we are recommending in these patients, so that we keep things under control.
Mhm. And doctor, what does the treatment for hepatitis B and C look like? Are they completely curable?
At this point, hepatitis C, the treatment, we are striving towards complete eradication. Uh, there's been a significant improvement and advancement in the type of viral medications that we have. Previously, we used to treat these condition, at least hepatitis C, we used to treat for a very long time, for almost 6 months and 9 months when I was in my training. But now it's come down with this new regimen of combination antiviral medications, come down to, you know, for it's come down to 2 weeks, I mean, sorry, 2 months, 8 weeks or 12 weeks of treatment, and it's proven to be very effective. So we
Mhm.
do go for complete cure for hepatitis C. For hepatitis B, it varies actually, and that's the nature of the beast. We keep the treatment going till we see uh, signs of complete cure, which is not very common, but it is possible.
Mhm. And doctor, how would you say that hepatitis is different from other liver diseases?
Hepatitis, it's an acquired infection. You get it from somewhere else. It's not something that you are born with. So awareness is very important. Um, it was the lack of awareness a few decades ago that led to the rapid spread of these conditions. Things like hepatitis C from drug use, from close contact, from sexual contact, all these things. We are not aware of it at that time. But now, a big part of tackling this problem is to be aware and to prevent them from happening, right? Um, After you get the infection, then the patient has to go through evaluation and get the proper treatment. Whereas other conditions, let's say you are born with inborn error of metabolism or something genetic like hemochromatosis. These are conditions that you're born with. There's no escape from it. Autoimmune hepatitis, those things, they just get diagnosed down the road, and there are different treatments for it. So at the end of the day, what we are trying to do with your liver is we try to address the situation, address the problem, treat the problem so that we prevent it from progressing towards cirrhosis and eventually needing transplant, things like that.
Mhm. Mhm. Thank you so much for breaking that down for us, doctor. I think we're gonna be taking our final question for today morning. It's been a good session. Thank you so much.
My pleasure.
Um, uh, so the question goes, my friend has had bloody stools, weight loss, and fatigue for a few weeks. Could it be something like Crohn's or ulcerative colitis?
Yes, definitely. These are, as I said in the IBS section, these are the alarm symptoms that you've mentioned. These are symptoms that are pointing towards something more aggressive or dangerous going on. It could definitely be ulcerative colitis or Crohn's. It could be other things also. Things like microscopic colitis or cancer can also present like this. So basically, the investigation should be to get a direct visualization of your colon with the help of a colonoscopy and biopsies.
Mhm. Doctor, what does the treatment for these diseases look like? Do you find that you use immunosuppressive drugs for these diseases?
See, once the diagnosis of IBD is established, we actually think that IBD is an immune condition in which the body itself recognizes the lining of your intestines as something foreign. So the example which I always give is like the corrupt cops turning on the population itself. So when the immune system is dysregulated, it's identifying or misidentifying your lining of your intestines as something that is not supposed to be there. It's going to attack it. So what we do is we try to reduce the intensity of the immune attack. We try to use medications that are reducing your immune potency. So the way to go would be to start people on uh, medications like mesalamine, steroids, azathioprine, which are immunomodulators. And now we have other agents like certain injections and biologic therapies that we can use towards regulating your immune system that reduces the amount of damage going on in your intestines. So yes, in a nutshell, yes, immunosuppressives are a way to go. There is a limited role of antibiotics as well.
Mhm. And doctor, do you find that there are long-term risks associated with these diseases?
Yes, we see this a lot. People who have lived with any kind of inflammatory condition for a long period of time, let it be in your food pipe, let it be in your liver, as we were saying, it progresses to cirrhosis. In the food pipe, it progresses to Barrett's esophagus and cancer. Similarly, in the colon and your other parts of your intestines, if you live with inflammation for a long period of time, the cells are damaged, they get repaired, they get damaged again, they get repaired. So this whole cycle continues itself, and that can proceed towards cancer development. So uh, before full-blown cancer happens in a person with inflammatory bowel disease, you have precancerous patches called dysplastic areas. So yes, left untreated, these conditions can lead to cancer as well. And that is what we need to surveil for. We're doing surveillance for these kind of individuals.
Mhm, mhm. Thank you so much for taking the time to explain that to us, doctor. Thank you so much. I think that brings us to the end of our session. I think that was a really quick one, wasn't it?
It was. Thank you.
Yeah, and to everybody watching us right now, if you found our video helpful, please do like the video and share it with your friends and family and subscribe to our channels. We have sessions every weekend with various specialists, and we're here to address all of your concerns. Or if you want to consult with Dr. Asad or any of our specialists, please go on to the My American Doctor website where you can access our telecommunication services, or you can call us on 9914941494. Thank you so much for taking the time, doctor. We're honored to have you. Thank you.
Appreciate you. Thank you. Thanks for having me.